Thank you, Mr. Chairman, and I would also like to thank Dr. Sparias and the organizing committee for this invitation. May I have the slides, please? Okay, now I do have them. So let's see what this crystal ball of predictions have for aortic valve in the next years to come. And actually, we now have a treatment which has been well established. Of course, at the moment, we are treating patients that are of older age, but perhaps this is about to change in the coming years. And we have several valves that are being used, each with its own advantages and disadvantages. And of course, we have two large studies in low-risk patients showing that TAVI is an established treatment for aortic valve stenosis and is at least as good as surgery. So what are we expecting for in the coming years? Well, the first thing is to try to have a procedural optimization to try and minimize all the complications of the procedure. So we do have improved delivery systems. All companies are constantly improving their systems in an attempt to improve depth control, flexion, and commissural alignment. We're also going towards lower size of sheaths. At the moment, we already have sheaths of 12 French, so in the cement valve, which is a two-piece valve. The current sheath is 12 French, and they are planning to downgrade it to 9 French. And the Roussakis that uses rhenium instead of nickel will have a delivery sheath of 8 French. This is still to come. What about conduction disturbances? Well, we're already in the process of minimizing it by using dedicated implantation techniques and have valves that focus on optimizing the radial force so that conduction disturbances are minimized. And of course, for PVL, all valves at the moment come with skirts or wraps that allow to minimize the leaks. Of course, we still have to look for how long a valve is going to last, and of course, what's going to be needed in the life course of a patient. So a couple of years ago, we had studied with Dr. Sathogiannis from here what are the long-term outcomes, and we had shown that actually the rates of structural valve deterioration are not that high, and they are also dependent on the valve size. But of course, all bioprosthetic valves are doomed to fail at one point or another. But at least with TAVIs, what we know from the long-term follow-up of the NOTION trial is that perhaps we're less prone to this degeneration than the surgical valves. And also that especially when we have a large annulus or use a self-expanding valve, then the deterioration rate is quite lower. But we are also working on increasing it, on having better tissues and testing its valve in order to extend its durability. And of course, the first step is optimal implantation in order to avoid things such as the ones that you see here, these deformations, this thrombus formation, and of course, all the things that are different from the bench experiments. And companies are working on better tissue, on tissue that has been stabilized in order to prevent degeneration. But also, new valves are coming that are trying to mimic the biological process and try to mimic the native aortic valve in order to have increased durability. And of course, there is the subject of coronary artery disease when we are discussing the lifetime management of such a patient, and also the question of what should go first, should be the coronary, should be the valve. This also should be done in the context of selecting which lesions we have to treat. and this is what we are testing in the escalation PCI TAVI trial. But what we have all seen is that, especially in the US, almost half of the patients that are lower than 65 years old are getting a TAVI. So what this means, that we're getting a lot of valve-in-valve procedures in the future, and most of these are derived from the TAVI-in-TAVI. And all this comes with all this consideration, both for the index implantation, but also for the follow-up about how we're going how we're going to treat such a patient, especially in the course of the lifetime. This means that perhaps there is some new room for leaflet modification, both in the context of a valve-in-valve, but also in the context of coronary protection, or even bicuspid valves. This can be done by the Basilica technique or with dedicated catheters. And then, the aortic valve might also have some new indication for transcatheter interventions. And this review summarizes all the potential targets that are coming in the future. But I think the most intriguing is treating the asymptomatic AR and moderate aortic valve stenosis. And there are several studies that are trying to see it, whether when you have moderate aortic stenosis with some cardiac damage, or you have asymptomatic severe aortic stenosis, you should intervene at the moment. The early TAVR study showed a benefit, mainly derived from the decrease of hospitalization, whereas the EVOLVE trial, which was actually not the planned size, did not show a clear benefit. Then again, TAVR unload study was also prematurely stopped due to slow enrollment. Didn't make a difference, but we're also expecting the progress and the expand TAVR study to see if there is a benefit in treating moderate aortic stenosis with cardiac damage. But of course, in moderate aortic stenosis, there may be a role for some emerging therapies, such as ultrasound therapy that may reduce calcification in the valve, or valvulopathy with a type of cutting balloon that do lacerations in the leaflets of the valve. And of course, there is artificial intelligence, which is being used more and more in this time, that may predict the disease progression either by ECG or by imaging. And then, of course, we have randomized studies that are trying to show whether TAVI has an established role in bicuspid aortic valve stenosis. And then again, we have dedicated devices for aortic regurgitation, either as an add-on clip or dedicated valves. JenaValve Trilogy has been tested with promising results in the LINE AR study, whereas J-Valve is also coming. So I think these are the three main things that we're looking for in the future: how we can make our procedure better with less complications, how can we treat a patient and make sure that we have a solution for the entire length of his life, and of course, see whether we can move transcatheter interventions to other levels. Thank you.
Thank you very much, Dr. Karanasos, for your nice and precise presentation. Please take your chair. We have to move on, and then